All right, everyone, welcome. It's Grand Rounds, and we have a very special one today. It's cold out there. It was 22 degrees. I've got on my warmest fleece, which I think is an underappreciated fleece from years past. This is today's CME code. Okay. We have applicants out there in the internet somewhere. Welcome to Duke. Hope you enjoy the Grand Rounds, and I'll be talking to you in about an hour. Today's All-Star Coffee Cup recipient is, I'm sorry, I got it wrong. This is why I love being a resident at Duke in neurology. It's Meg, the great Meg Sagita. And she talks about just what a great place it is because of everyone loving to teach. And that's certainly been my opinion of the place here. We have so many attendings, residents, and fellows who really value teaching, and it's a great place for that reason. Thank you, Meg. Our holiday party is 2.5 weeks away. I don't know what time it starts. Does anyone know? It's like 7:30. 6:30. Wow, that's appropriate. We have an early bird special part of it if you get there really early. It actually is much more fun than these pictures indicate. So it's not so bright. So Friday, December 15th, RSVP to Maria or just come. Our all-star, sorry about this, is Steve Pollock, who works in the Maureen Road Clinic, nominated by Daniel Parker. Spent a lot of time with a very frustrated patients. And I know our clinic staff and medical assistants are the face of Duke to our patients. And we really appreciate that, Steve. And you're about to get a very beautiful coffee cup for it. A little bit of research roundup. Rahul Graini and Elijah Lackey, along with a couple of students, looked at how a mutation in the COL4A1 gene affected their childhood epilepsy. Good work. Kathy Welsh-Bomer was the first author of an article looking at the state of clinical trials in Alzheimer's disease. It's really hot and heavy over there now, and that was in Alzheimer's and dementia. This day in science, I looked up, like, was it National Pizza Day? Today was really a bad day for national days, so I went to this day in science. So Charcot was born today in 1825. I'm sure all of you know about Charcot, who's considered the founder of neurology. I did not know that Sigmund Freud was one of his students. Sigmund Freud, as you also know, was also a neurologist, although he's kind of famous as a psychiatrist. Today in 1944 is a very famous day in cardiac surgery. It was the first blue baby surgery at Johns Hopkins, done by Alfred Blaylock and Helen Taussig. It didn't fix the heart, but it developed a shunt between the subclavian and the pulmonary arteries to reoxygenate the blood in babies with congenital heart defects. And it was really a milestone in surgery. Today is also the birthday of Antonio Moniz, who is famous for both cerebral angiography and much more famous for frontal lobotomies. This is the man who developed the frontal lobotomy as a way to treat psychotic symptoms and severe depression before there were medicines. He initially did it in the 1920s by injecting ethanol into the frontal lobes to just kind of coagulate them. Then they changed it to an incision through a burr hole in the skull, and then finally through the eye, a 5-minute procedure that you'd be in and out of in no time. Over 60,000 were performed in the US. It died out in the 50s with the development of antipsychotics and antidepressants, which led to what I think is like one of the greatest lines of all time by Tom Waits, who was kind of my generation's Harry Styles. He said, "I'd rather have a bottle in front of me than a frontal lobotomy." And that's actually really funny. So Tom Waits I didn't know he's a member of the Rock and Roll Hall of Fame and is number 55 on Rolling Stone's 100 Greatest Songwriters. And I couldn't name one song he wrote, but I still remember this phrase. Again, today's CME code is TUML. There's no case today, and Joel is going to present our speaker.
Good morning. So Today is actually the second annual North Carolina Neurological Society Grand Rounds at Duke. This program got started by the society last year to try to bring visiting speakers into our institutions and also give a chance to update people about the North Carolina Neurological Society. So especially for new faculty and house staff, we have a very vibrant neurological society in this state. We have an annual meeting that this year is February 23rd, 24th, and 25th at the Grandover in Greensboro, a short 50-minute drive from here. And we do a lot of things for house staff, APPs, and neurologists. So from the house staff perspective, we have a meeting that is free, and it's quite a good meeting, so you can take advantage of that. We also have a poster program. So if you present a poster, then you get a hotel room night free. And abstracts are actually due at the end of this week. It doesn't have to be like your extraordinarily fancy randomized controlled clinical trial. Case reports are wonderful. Something to teach us about whatever you're interested in teaching us is what we're looking for. We also have the Neuro Bowl that got started last year with our guest, Dr. Strowd, as the host, and Dr. Ryan in the back was the captain of the Duke winning team last year, which was a lot of fun and really good courses. I mean, we have speakers from outside of the state, including Sean Pittock coming from Mayo Clinic to talk about autoimmune encephalitis. We have lots of speakers from within the state, including many of our faculty and house staff. So it's really going to be a good meeting. And it's really close. And we also have a great APP section that's led by our own Erica Cummings. And she will have a lunchtime gathering for APPs. So we really would like to welcome everybody. You should have gotten an email with the program. If you didn't, send me a note and I'll send you another one. And everyone is definitely welcome. So as part of what the society is trying to do to sort of up our game with academic institutions, including our subspecialty Sunday, where we have subspecialty lectures on neuromuscular disease, stroke, epilepsy, and MS. We started this lecture series, and it's really my pleasure to welcome Dr. Roy Strowd back to Duke. Dr. Strowd was a graduate of Duke University and continues to be a Duke basketball fan, although I didn't ask him what happens when they play Wake Forest. Dr. Strowd did his medical school at Wake. He's been at Hopkins for both his neuro-oncology fellowship and his master's of education. And I would say that, you know, what I'm really happy about is that Dr. Strowd is really one of the national and international leaders in neurological education and education in general. He's an associate professor at Wake and also the vice dean of undergraduate medical education and very involved in the new medical school that's starting in Charlotte through the Wake system. He's going to be talking to us about creating opportunities for clinician educators through educational scholarship. So please welcome Dr. Strowd.
And I would like to mention that Katie noted that today is World Movement Disorder Day, and I would just like to know that wouldn't be listed on the websites I visit before today's lecture, and apparently not on the websites Will visits either. But thank you for telling us that, Katie. There we go. Oh. I'm sure Roy could do this quicker than I can. That's what they say when you get old. You look great. Yeah. Do you know about floating meeting controls? Yeah, I'll go ahead. How are we looking? Can people hear us? I don't mean here. I know you can hear. All right, they'll tell us. All right, Roy, take it over.
Thank you so much. Well, thank you. It's great to be here, and it's great to be back. I was last here over the summer with my daughter. She was here for 2 weeks. She's 12, and got to spend 2 weeks in a Duke dorm and figure out what college is like as a 12-year-old. And so now she's like set to come here, which means my wife and I are royally screwed. We got to, figure out how to handle tuition and those sorts of things. But it's a joy to be back at Duke. We had a great dinner last night, and I'm really excited about the talk today and the focus on neurology education. I'm going to make this as interactive as possible, definitely for those who are in the room, and I'll try and figure out how to bring up the chat for those who are on the chat as we go through. And I hope for those who are educators, you can take something away about what's happening in education today. For those who don't consider themselves card-carrying educators, we're going to talk about some things that are going on to enhance patient care through education. And I hope you can take some things kind of back to your care and those sorts of things. Right. So just one disclosure that's relevant for today. I am the editor of Neurology Education, and most of today's talk will be about work published in neurology education. I was going to mention the North Carolina Neurological Society, but Joel just summarized that tremendously well, and he is quite modest. Joel has really expanded the society's offerings to academia and academic neurology in the state. This subspecialty Sunday is phenomenal and would really encourage you all to attend. And I would love to call out Erica as well. Erica has been involved in the society probably for the last 4 to 5 years and has really changed the face of hopefully what the society is for APPs, NPs, and PAs. And many thanks to Erica for doing that. She's actually now on the society's board as one of the executive members. And so a great opportunity with the society. So where are we headed over the course of the next 45 minutes? We'll start with an introduction to or overview, a reminder of the journal, Neurology Education. For those who are not familiar with it, want to get you up to speed. And those who are, we'll highlight some of the new things that are happening in the journal that may be of interest or value to you as an author or an educator or a reader. We'll spend most of today's talk talking about these 2 articles. One is an education research article, and the second is a curriculum innovation. And you'll hear kind of what are those 2 article types and 2 different ways that we're improving training for neurology residents and patients in neurology as well. I probably won't get to part 3, which is, how do you use scholarship? How do we use scholarship as a field to enhance what it means to be an educator, to enhance the field of neurology? And we could potentially kind of spill this into questions at the end or those sorts of things. So we'll start with a discussion of the journal. So Neurology, the Neurology family of journals launched Neurology Education a 1.5 years ago, April of 2022. This is the newest in the Neurology family of journals. There's N2, there's Neurology Genetics, Neurology Clinical Practice, and Neurology Education is the latest spoke journal. This, for those who aren't familiar with it, it is an online-only journal. It's a peer-reviewed journal, and it focuses on disseminating evidence-based teaching practices. So those are new teaching methods, curriculum innovations, new curriculum for students, for fellows, for faculty, throughout the continuum of neurology. And there's also a number of ways the journal is promoting an exchange of ideas. And we'll talk about some of the peer-reviewed scholarship through the journal, as well as kind of non-peer-reviewed and other outlets through the journal to disseminate teaching work. The audience is educators, but that's a very broad term. So preceptors, fellowship, clerkship, program directors, basic neuroscience educators, neurologists, neuroadjacent fields. So a broad audience that the journal seeks to cater to. And this QR code takes you to the journal's website, and there will be a few as we go through if you're interested in checking it out. What are the publication types for the journal? It is a research-focused journal. So 3/4 or more of the articles fall in this research area, education, research, and curriculum innovation. And we'll walk through kind of what those are over the course of the talk. There's a really neat 3rd research type of article, the neuroscience of education. That's sort of what's happening in the brain, what's happening from a neuroscience perspective when learners are learning, when teachers are teaching. Those may be fMRI studies or EEG studies or behavioral assay studies, but what is the science, the neuroscience of education? And so if that's work that you're doing, we're very interested in those types of articles. There's also a number of non-research articles that may be of interest to new educators or those who are interested in doing this work. We have a method series that's about to come out starting over the next month or so. It's the Funner series. It's always nice to have a good acronym. So it's Fundamentals of Neurology Education Research. And it will start with a paper on conceptual frameworks. How do you use a conceptual model to ground your education research study? And then walk through quantitative methods in education, qualitative methods in education. So if you're interested in doing any of the work that we talk about today and just don't feel like you have a handle on how to do that, this is a series that can help to provide that background. There are a number of neat reviews that have been published. There's just a review on gamification. For those that know Zach London, he's a big game maker in neurology and has published an article with a group on how do you use a game to teach, and not just to have fun, but also teach the foundational science of neurology, as well as a review on simulation in education and those sorts of things. History of medical and neurologic education is great. So it's World Movement Disorder Day, and how did we get there, and how can we use the history of how we got to where we train today to know where we move into the future. So very interested in history of neurology education articles. And then I'll mention these tweetable teaching images as well. And that's what's next. So we're also very interested in cover images. Not all of the education manuscripts have a great MRI image we can put on the cover. And so a lot of our cover images come from these tweetable teaching images. These are handouts. They're visual aids. They're things that are in your pocket as a resident when you're on rounds, or that you're sharing in clinic to teach the student, the resident, the fellow who's with you. They come with a 100-word executive summary of how you as an educator or a learner would use this to teach those around you. The first one we had was from a medical student who took a course on art in medicine and created kind of 3 graphics on localization. So localization of stroke, upper limb pathology, lower limb pathology, showing brachial plexus, lumbosacral plexus, and how you use this to teach clinical disorders in those areas. We had a teaching image on how to characterize, epileptiform discharges, and how you can use that to teach residents and fellows, in the EMU and those places. And then one, speaking of movement disorders, Katie Moore, on differentiating features of head trauma-associated Parkinsonism from idiopathic Parkinsonism, and sort of things you could pull out of the journal or print off and use to teach those around you. How does the journal work? We do use a continuous publication model, which is ideal for authors. So articles that are accepted or typeset and those sorts of things takes about 2 to 3 weeks, and then they are published. There's no waiting time to an issue. That work is out there. It is online only. There's not a print issue, but articles are put together in issues 4 times a year. And we try and organize those around themes so that you can click on the issue, pull it up, and sort of read through and walk through something that makes sense. So student articles may be grouped together and resident articles grouped together. Oftentimes we will thematically arrange articles so it sort of makes sense when you end how you would incorporate this into your teaching practice. Importantly, all articles are published open access, so they're freely available to everyone, but there is no article processing charge for authors. This is through support of the Academy, which supports the journal and the dissemination of those. The journal is not yet indexed. We're going to put our application for searchability in PubMed together in January of 2024. And ultimately, all articles will be freely available through PubMed for the entirety of the journal, all those that have been published to date and then moving forward. And no impact factor yet, but that will be something that the journal will seek out in its kind of 3rd year. So this is one of the last few slides of the journal. So what have we been up to and what's happened over the last year and a half? As I mentioned, the journal launched at the annual meeting in April of 2022. And there has just been a ton of interest in submitting and disseminating work from educators throughout neurology. So we've received, as of September of this year, over 200 submissions, most of those being those research submissions, which I'll show you in the next slide. And for those that publish in medical education, you know that usually it takes like 6 to 9 months to hear back from a journal, and that is not true of this journal. So our average time to first decision is 27 days. You submit, you hear what the decision is, and we want to get your work out very quickly. These are the articles that have been submitted. So the vast majority, 3/4, fall in that education, research, or curriculum innovation. So those are the ones I want to talk about today. We haven't had as many history, reviews, tweetable teaching images, and those things. So if any of the things I talked about just now is of interest to you, those would be things the journal is interested in receiving. And this is sort of the audience type of the submissions to date. We get a lot of work on resident education, a decent amount of submissions on medical student education. We're very interested in the pipeline. what's being done at Duke, what's being done around here to promote and expand the pipeline of those interested in neuroscience and neurology and neuroadjacent fields, in APP training and fellowship training and continuing professional development for faculty. So if those are things you're doing, we're very interested in that work. And then lastly, I want to mention the blog. The journal has a very active blog, which is a place for commentaries, editorials, things like this, educator recognition. This was put together by Andy Sutherland and Jet Ratliff at the passing of Ted Burns. And so recognizing those educators that are around you who are doing this work. It's a great place for works in progress. This was a work in progress from a medical student at Yale, talking about using a near-peer podcasting tool for teaching fellow medical students. So using kind of podcast to teach fellow colleagues and students. It's a great place to get early works, things that you've just started or piloted, and get that out there to others. It's a great place if you're a learner to talk about your perspective on learning. And we also have a highlight of some of our authors there. How do you be an educator? How do you do this work? And so summarizing some of those things. And then the last slide on the journal is we love to get people involved in educational scholarship, and there are opportunities to be a peer reviewer. We have an open call for peer reviewers if you're interested in doing that. We have an annual trainee editorial board program. This is a one-year sort of internship program with the journal. We accepted 6 new trainee ed board members in September. These are senior residents and fellows who spend a year with us learning how to peer review, learning what educational scholarship is, and being a part of the editorial board. And we have a very active editorial board. We meet once a month, talk about how to move education forward in neurology with broad representation, both inside and outside of the field of neurology. So I will pause there. Happy to take any questions you may have about the journal or those sorts of things. Any questions? Maybe difficult to get the, I don't know how to move the. Yeah, can you get it back? Yeah. All right, sounds good. All right, well, we'll move forward. Yeah, good. We'll move forward. I may ask for some help from someone online as we go. So happy to take any questions you have about the journal as we go through the talk. Most of what I wanted to discuss was, what are some of the works that are coming out in neurology education? What are the things that you may be doing here that are relevant to articles that have been published, and what could be put together? So I'll talk about 2 articles that I think are good articles. They're interesting things going on in neurology education, and maybe helpful ways to frame some of the work that you're doing in teaching. And we're going to try and make this as interactive as possible. So those that are joining virtually, I would love for you to use the chat. And I can't see the chat, so I'm going to ask someone to kind of shout out online of what may be happening in the chat. And then here in the room, just by a show of hands. So question, do you practice mostly in an outpatient or inpatient setting? I think we have a lot of residents here. So maybe non-residents in the room. Do you practice outpatient? Do you practice inpatient? Outpatient. And decent number of hands. Inpatient? 1 soul. Well done. All right, how about the resident audience in the room? Are you outpatient practitioners? Are you inpatient practitioners? What are you, outpatient? We got 2, we got 3, excellent. Okay, inpatient? Yeah, slightly more hands. And some of those that are outpatient also raised their hand for inpatient. Yeah, I can't see what's online, but would love.
We've got a 5-to-1 response
Oh,
of outpatient to
fantastic. Thank you for
inpatient.
that. See? Metro O'Brien, you are the tech extraordinaire. So we got a lot of outpatient coming in on everything's okay. Thank you, Matthew Elric, for representing our inpatient crew. So, not surprising, no surprise here. The first question's got to be easy to get you to participate. So, the vast majority of neurology happens in the outpatient setting. And yet our resident kind of corner here is spending the vast majority of their time in the inpatient setting. And so this has been a question that has frequently come up in the journal. And the article that I'll highlight today, and would love to get your thoughts on this, is one from the UCLA group. And this is a group that looked at the effect of an X+Y scheduling model on neurology residency training. And so the problem that they set up is exactly what we just discussed. So 90% of neurology residents indicate that they will do a fellowship. And by and large, that's to gain confidence in the outpatient neurology that they will go on and practice. And only half of those that go do fellowship will actually take the board certification in that fellowship. So sort of why are they going and doing fellowship? Fellowship applications occur early. And so this is a challenge that Maria and I were talking about last night of just, you got to know what you want to do before you've even experienced it. We need more outpatient exposure earlier in training, and adding outpatient clinics during inpatient service adds to stress and burnout for residents. And so that was the problem that's painted by this group at UCLA, which is not surprising. This is something we're experiencing, everywhere. One solution that they saw has been looked at for now several years in internal medicine and peds, and that's an X+Y scheduling model, which I'll describe. And so this is separating inpatient and outpatient training and inpatient outpatient weeks. There are X weeks, which are only inpatient, and Y weeks that are only outpatient, and so dividing up those areas of clinical rotation. And so the gap that they describe and wanted to address with this study is, can an X+Y scheduling system be feasibly implemented in neurology? There are differences in neurology. IM and peds have buckets of residents. They're able to change their schedule and maintain coverage. Is that something that can be feasibly done in our specialty? And so this is the intervention that they looked at. They looked at a 4+2, an X+Y, a 4+2 scheduling model. And they compared their existing framework for PGY2 rotations, which is this. This is not unfamiliar to the resident crew right here. There's a lot of gray. There's a lot of inpatient weeks, inpatient months over the course of a 12-month year. And there are dedicated months, those are in green, that are fully outpatient. And that's the typical and traditional model. And they compared the resident experience with that, A, to the post-intervention model. And this is the X+Y model. So here we're looking at 2-week blocks. And there is an inpatient week and an inpatient week, followed by an exclusive outpatient week. Inpatient, inpatient, outpatient, inpatient, inpatient, outpatient, dividing up those areas of coverage. And this is what the outpatient week looks like. So a ton of subspecialty neurology that's experienced from day one, or at least week 3 of the PGY2 year, with residents going through the otology clinic and genetics and movement disorders and behavior. And shame on them for not including neuro-oncology on this list, but tremendous outpatient subspecialty exposure. And the unique thing is residents are then able to go to those clinics regularly and follow patients longitudinally over the course of the year, because they're in that neuro-otology clinic every month, and able to see some continuity of care. And so they evaluated this model for PGY2 residents, 10 residents before, 11 residents afterwards, and looked at a number of things. And so what did they find? Not surprisingly, they found that there was an increase in outpatient exposure. That's what you just saw on the last slide. There was more green, so 15 weeks of outpatient training for the PGY2s compared to 4 weeks of outpatient training in their pre-intervention model. There was an increase in continuity clinic, increase in patient appointment slots. So we start to think about utilization and patient access actually being improved by this for the residency program and the department in general. Less handoffs. Handoffs are patient safety risk events and opportunities for patient safety concerns. And so reduced handoffs as a result of this, and no change in the work hours. So it wasn't adding stress to this neurology residency program. And so important findings, but not particularly exciting. Those are things that you would expect to happen in transitioning to this. So what made this study and this paper kind of interest to the journal? They also looked at what learners thought about clinic. And not surprisingly, they found improvement in what the residents said in clinic. And they looked at a satisfaction scale. So how satisfied were residents? And we're looking at before to after. More blue is more satisfaction. And they looked at 3 things. So resident preparation for outpatient practice improved. Residents had dedicated time to prepare for those clinics, to read about subspecialty areas in neurology before going and rotating in the clinic. They weren't running from the inpatient service. They were able to dedicate that time. Their ability to follow a condition was improved, and ability to focus on responsibilities during clinic was improved. Also not particularly surprising. That's what you would expect. What did learners think? What did residents think about inpatient service? Well, actually, the same thing was true for the inpatient service. So amount of time to learn on the inpatient service improved, time I can spend with my patients during inpatient service improved, and ability to follow and focus on responsibilities during inpatient service improved. So the lives of the residents were improved in clinic and in the inpatient setting. But perhaps the most important kind of outcome I think this group looked at was things like stress, fatigue, and the well-being of residents as a result of this kind of shift in the scheduling model. And they looked at a number of things. They looked at job stress, fatigue, and personal reward from that rotation. And so each of those in the clinic setting improved. So there was less job stress, less fatigue, and more personal reward from time in clinic. That's really, really important. We want residents to be pursuing outpatient neurology. We want them to go to clinic and say that was a rewarding experience. I can really meaningfully impact the life of a patient in that. Interestingly, they found the exact same thing on the inpatient side. So less stress on the inpatient service, less fatigue on the inpatient service, and more reward in taking care of patients when you can focus on that and aren't dealing with the challenges that may be encroaching on inpatient service from clinic and the things encroaching on clinic rotations from the inpatient service. So this group puts forward in their discussion a 4+2 scheduling model in neurology is feasible and so important for the field, increased clinic time, increased resident satisfaction. They actually saw improved right scores for outpatient topics earlier in training, reduced handoffs, did not change work hours, and enhanced well-being. So what made this article a must read? What was the value of this type of article for neurology education as a field? In the discussion, they get to this topic. And it may be that at Duke, it is not the case at Wake that we've moved to a 4+2 model. And that may not be the only way to do what was done in this intervention. And the authors sort of talk about this model for psychological safety. So a lot of residency is spent down here in the anxiety zone. Right? A lot of accountability. The service is yours. The clinic is yours. That's your responsibility. But not as much psychological safety when you're oscillating between those two, when you're covering pages in the middle of seeing a patient in clinic or handling phone notes and other sorts of things when trying to manage the inpatient service. And as a result of shifting to this model, this 4+2 model, they moved their residents into the learning zone, where they're able to focus on the outpatient setting and focus on inpatient training and the inpatient training and create that psychological safety. So maybe that is the 4+2 model, but there are probably many other interventions that you're doing here and that you can think about doing here that would also enhance that part of training, improve the lives of the residents, and also improve the care that's provided to patients. So I'm going to move to the next article, but I'm going to pause first and see what questions do you have, what comments do you have? Is this something that you've thought about in your residency program? Residents, any comments on kind of how you think this would impact you? Comments and questions from those who are here in person or online. We can see the chat now too. Dr. O'Brien.
As an old man, I just find there's so much resistance to any kind of change. I still can't believe that they're pretty much doing what we did 35 years ago. And I think the resistance comes both from the residents and from the faculty.
It's a great point. Nobody likes change. That is, I think, that was one of the goals of this author group. Is to put some data out there that says, look, you can do this. And this was a 1-year pilot. And if successful, it was going to move forward. If unsuccessful, it was not. They have moved forward with this model based on these data. So I don't know what others think about change. Is this feasible? Could you do it? Or those sort of things. It's a great point. Other questions?
Yes. Was there an impact?
We can barely hear you. Speak as loud as you can. I think we'll be very quiet, see if we can hear.
Yeah, I was just asking if there was an impact on the inpatient skills, including inpatient knowledge and performance on the right exam.
Try again, Felix.
Do you mind just repeating the question?
I was asking if there was any impact on the inpatient skills and if that affected in any way performance on the inpatient right exam aspects.
It's a great question. Was there any impact on inpatient skills? They didn't report or look at inpatient skills specifically. They didn't look at, kind of decisions from the CCC, milestone achievement, or didn't do any OSCEs or anything like that. They did look at right scores, and they did look at right scores for kind of inpatient conditions. There was no change in those. They looked at for outpatient conditions, and there was no change in those. And they specifically called out outpatient conditions, headache, MS, movement disorders, and other areas that aren't sleep medicine, actually sleep medicine, headache, and there was one other that are infrequently encountered on the inpatient service. And these are PGY2s, and scores were improved, right scores were improved for those conditions after this intervention, which is also not surprising. Residents are going to those clinics regularly throughout the year and seeing those patients. And so, learning of those outpatient conditions was brought earlier in training. It's hard to know what to do with that because residents are still going to learn that later in training without this model. But it is a good, I think it is a clear demonstration that there was earlier exposure to outpatient neurology at a time when residents can then consider whether that's a specialty they want to pursue. Andrew.
So about, I don't know, 7, 8 years ago-ish, we did make a switch to do this, not 4+2 specifically, but it is the idea that we put a lot more outpatient time into the PGY2 year for a lot of these reasons, also the early match for the fellowship. So we've been doing that for about 7 to 8 years. The consequence was more inpatient time later, which I think still is better for well-being because they're in that much more of the comfort and education zone because they're less anxious at PGY4 than they're at PGY2. I don't know what PGY level we're looking at.
This was just PGY2s.
They report what happened to their 4s
so
when they made the switch to 2s.
Yeah.
I was going to add something similar, which is if they're getting more outpatient exposure, it needs something that to adjust on the inpatient side.
Yeah. So the two questions in the room for those who are joining virtually is, well, what happened to this inpatient coverage? Because if you add outpatient time in the PGY2 year, you're adding inpatient time in the 3 and 4 year. So because of going to this type of 4+2 model, there was no shift in inpatient coverage to the senior residents. They were able to cover the services with the same cohort of residents, year of residency. They were sort of just doing it by the schedule as opposed to kind of shifting it in over the course of the 2, 3, 4 year.
So they were resorting when it happened, whereas we actually just added outpatient time.
Exactly.
More just a scheduling change.
Exactly. So they resorted, how the 2s were covering inpatient services and not kind of changing when that was done during the PGY years.
The other issue, which I didn't see addressed, is there are 2 consequences of doubling up on continuity clinic. One frustration for the residents when they do a lot of rotations where they're not in clinic, like our ICU, I think, and our consult service, is that if you have to see one of your patients, you could maybe not be in clinic for another 6 weeks. The other thing is, if you think about what the RRC would want people to do on continuity clinics, if you're doing 2 a week every 3rd month, they're probably not happy with that. They probably want people in continuity clinic on a monthly basis or equivalent. I mean, I'm not sure that
this is a great point. So how do you handle continuity clinic when basically your continuity clinic is just once a month? Because that's what you were seeing in that model. One of the things that they talk about, and I know that other internal medicine PEDS programs have done, is do a shared continuity clinic model so that there is a more frequent time that residents would be basically sharing a clinic. 2 residents would handle 1 clinic so that those patients can be seen or worked in if they have issues other than just once a month. So there is some challenges to handling that continuity piece. And there was more continuity clinics in this model, which could or could not be a part of this kind of model moving forward. There's one question in the chat. Did the group also evaluate whether subspecialty selection or plans were changed after this intervention? That's a great question. The answer is they didn't look at that. And there wasn't longitudinal data years later to see whether there was a change in subspecialty interest. They did ask the question of residents, what are you more likely to consider an outpatient career? And that did improve, but whether there was a true selection of that outpatient career is something that they didn't look at. Dramatically. So Chris Eckstein just said that when you all made this shift, that you did see a shift in outpatient career selection. So that'd be a great article to write and submit, I think. And it's great. We're all wrestling with this. There's three challenges here. One is how do you get exposure early enough that residents can be exposed to things before they're applying to fellowship? How do we get more people into outpatient neurology and general neurology and doing those trades that are critical to our field and patients? And how do we make the lives of the residents, as optimal as they can be? Yeah, Maria.
What was the basis for their decision doing like a very schedule over the period rather than like a block that's a little bit more immersive? And on one hand, to get more continuity with the schedule you're talking about, but it also is a little bit like.
It's a great question. Great question. So Maria's question is, why was that outpatient week a variable schedule? Couldn't you just do movement for a week and then sleep for a week and headache for a week as you do those outpatient specialties? This is actually something Joel and I were talking about last night, is the Y weeks tend to be with the same faculty member. So there's an opportunity to gain some longitudinal mentoring, which is not something they looked at through that consistent outpatient practice exposure, which is really influential for the faculty member. It can be very influential for the resident to get a longitudinal mentor, an outpatient mentor, and have kind of longitudinal experience with that faculty member as well.
Thanks for the comment. It's interesting to think about psychological safety, because when I think about second year residents, those that are struggling, it's often happening year one, and certainly once they get into neurology year two. And each individual doesn't cope the same in the anxiety zone. We know folks that actually do even better in the anxiety zone, right? And then folks that really struggle in the anxiety zone. So I wonder, when we think about our systems, if we think about psychological safety and we are intentional about moving everyone up to the comfort or learning zone, what would that do to successful completion of residents?
It's a great point. So Jody makes the point of, do we want everyone in the learning zone? There can be there can be benefits of learning to handle some of that anxiety. This is actually really, really important. And so some people call the learning zone. Some people call it the performance zone. And really, ideally, we want all of ourselves to be there. That performance zone is high accountability. So there is no reduction in the accountability. The skill set in handling stress, in performing maximally, but you're just in a place where you can actually do that. So there's no less anxiety for residents who are seeing patients in a busy outpatient specialty or a busy inpatient service in this X+Y model versus the other model. There's just as much kind of anxiety, but the ability to perform in that was improved. So great point. All right, I'm going to move to the second article just so we have some time to talk about that, and happy to take additional questions about this or our next paper as we go. So the second question I have for those in the chat or those here in person is, when you think about an exemplar in neurology, there's just, that's a neurologist, right? That's an exemplar. Who do you think about? And if those online would put it in the chat and those here just shout it out. Who do you think about? Anybody? Charcot, right? Charcot, we just talked about him, right? That's an exemplar, right? So nobody here knows him, I don't think, but yeah, definitely one of those names you think about. Others? Joel Morgenlander, absolutely. His picture, he's right here in the front. Yes, absolutely. Others? Eckstein, okay, I like the call outs. Excellent. Oh, wow, okay, well, yeah, now the bar's low. Okay, excellent. Anybody online, when you think an exemplar in neurology, like who are those role models? Who do you really think about? Like Espe, great name. Thank you. Movements. Mark Hallett, okay. Thank you, Katie. Mark Skeen, we saw Dr. Skeen on. Others that come to mind. Thomas Bleck, thank you. Yeah, I mean, there's, Marty Samuels, right? There you go. Larry Goldstein, right? Great guy, right? Ted Burns, right? We saw his picture. I mean, this is important, right? Who gets you into the field? Who gets you excited about doing neurology, right? This is, Ted Burns is was at UVA for a long time, program director initially there, a lot with the Neurology podcast. And that's what I can't remember Ted's neuromuscular. Thank you, neuromuscular. And passed away several years ago. So yeah, I mean,
Janice Mass?
Janice Massey. Yeah, absolutely. Absolutely. So, I mean, you can continue to think about this. We may kind of weave this into this next paper. Those online, if you want to keep populating, it's always nice to kind of see, who influences you, in neurology. We'll come back to this, but we'll get to this second paper. So this is a paper from the group at Harvard. It was a kind of a diverse group, but came out of the Harvard group. A curriculum innovation, so a slightly different paper in how it was put together. And this group sought to address some similar issues in neurology, improving residents' knowledge and interest of outpatient neurology through a patient-centered didactic series. So the problem is not so dissimilar. They describe in their introduction, the arguments they put together is there's insufficient knowledge of outpatient specialties, inadequate preparation for the responsibilities of an outpatient provider, and limited exposure to two things: longitudinal management and effective shared decision-making. So these are similar things that we were talking about in the first paper. And the objectives of this curriculum, this was a curriculum intervention innovation, were to improve residents' understanding of roles and responsibilities of the neurologist in the outpatient setting, share with residents the patient perspective, and improve residents' understanding of shared decision-making. We'll describe how they did that and what they learned and how you may be doing that here. So their intervention was a storytelling curriculum. So this was 6 noon conferences. Not 600, not every noon conference, it was 6. You probably have 6 noon conferences that you consider some type of intervention. And their goal was to bring the patient story into that noon conference, similar to what I think many residency programs used to do, but has gone away with COVID. But they sought to sort of bring this back. So in these 6 noon conferences, they brought a patient, their outpatient neurology provider, and a resident to share the story of what it was like to deal with that disease longitudinally. And the discussion was focused on the longitudinal management. It wasn't just the presentation. It wasn't just the initial story. It was that longitudinal piece, how they wrestled with what to treat when and when not to treat and those sorts of things. They piloted the program with patients that had a TBI, ALS, Parkinson's, dystonia, epilepsy, migraine, and then realized that actually disorders where there was a heavy discussion of treatment was more valuable for discussing longitudinal management. And so moved to these 6 areas that you see on the right: muscular dystrophy, migraine, MS, Alzheimer's, epilepsy. And actually, this was a really helpful way of discussing the management of functional neurologic disorders. They looked at a number of things. They looked at each of those objectives, and residents said that they were able to learn these things. But what made this a valuable paper, I believe, is the evaluation of all of the stakeholders through some qualitative data. So they got written surveys from the residents, from the faculty, and from patient interviews. And I'm not going to go into the details of the kind of quantitative stuff. They found that residents tended to like this and got something out of it. They heard the patient story. They were able to see what it's like to be an outpatient neurologist. And they studied this in a small group, 55 residents, but were able to draw some meaningful conclusions from that. So I want to walk through each of those groups' perspectives. So what did the residents say was the value of this type of noon conference? Well, residents discussed the central value of the patient perspective. It was important to hear directly from the patient how our treatment decisions impact people's lives, able to hear that story at a time when you're able to really hear it and think about it and kind of digest it as a resident. The session format supported learning about outpatient management, and seasoned faculty were able to serve as role models, how the patient's management with empiric trial and error management of headaches happened and how the faculty managed that. And, I want to be like that faculty. It was nice to hear that. So I think we'll describe some of the other perspectives. I think residents say a lot of this about clinic, and so you can get some of this about clinic, but there were some other benefits of this type of conference. So the faculty said that it strengthened the patient-clinician relationship. It brought me closer to my patient in a way that I wasn't just by seeing them in clinic and talking with them in clinic and those sorts of things. And it increased understanding of outpatient disorders. The residents realized that all functional patients have brain conditions, even if we don't know how to diagnose and treat them, and that having that attitude towards a patient is valuable in the care. So the faculty benefited from this. And then lastly, the patients benefited. Patients, were able to help physicians learn about and value the patient perspective. I think They don't realize how my background affects my knowledge and experience. And I was able to deliver that, to teach that, to help the residents and maybe the faculty learn that. The patients were able to give back, sharing and teaching is a way to give back. It was great to hear that what we went through as a family is paying off and helping others. And then the patients were able to learn something new. So I already knew that my neurologist was thinking about my case, but there were things that my doctor said, that she said to the other doctors, that made me think about it in a different way. You know, I learned and grew as a patient as a result of going through this. So these authors put forward that this was a way to discuss really longitudinal management of outpatient neurology in a way that's difficult to get from a 4-hour clinic or even multiple 4-hour clinics, that you were able to really talk about the kind of trials and tribulations of longitudinal management of neurology. And I think this gets back to that kind of exemplar, kind of topic. So you all mentioned many of these people. You guys got a lot of exemplars out there, and we spend a lot of time thinking about how to put residents and students and fellow into a clinic with a exemplar, with a role model, with someone who can help to inspire them about neurology. Dr. O'Brien, I think the difference that this author group puts forward is that, this was really about patient exemplars, and that being able to see the patient at a time where they're thinking about what it was like for the patient to go through this. How was the patient interacting with the outpatient neurologist? How are they experiencing longitudinal care that you're not always talking about when you're talking about how do we diagnose this ALS? How do we deal with this MS treatment decision and this kind of isolated decision? And those patients tended to be attainable and relevant to residents as they were focusing on this type of conference. Yeah, it was about seeing patients and their relationship with outpatient providers differently in a setting where they're talking about the longitudinal management, not talking about the individual clinic sessions decision. Yeah, exactly. And the patient's voice is kind of elevated in that process. So we're getting close on time, so I'm not going to go through the article blitz, but we'll open it up to questions about this article, questions about this type of approach. Is this something that you all do or have done? How does this work? Questions, comments from the room or from the virtual audience? Do you do anything like this?
In the old days, right, they always have the patient come in, some important professor who'd be out there. That never happened.
Yeah. Same is true at Wake. We used to do this, and it's not something that we've incorporated in several years.
The president had a very powerful new conference this week where the speaker was actually a neurologist who had ALS. And he spoke about it from both sides. And I thought that was very compelling. And also sort of the relationship of, how doctors go to get health care within their system when they have a problem.
Yeah.
How that might change kind of how you treat it.
Joel mentions a noon conference from a neurologist who has ALS, talking about just what that was like and the power of that. I don't think this happens as much because, we do a lot of this hybrid stuff now. And then, COVID was sort of patients aren't coming in and those sorts of things. There may be a way to think about that a little bit differently, right? It may be that the Zoom really allows us to bring patients in without coming in. And how can we use Zoom to elevate that patient voice and bring patients into the discussion and actually do that without the patient having to come in and sit here and, those sorts of things. There may be some ways to increasingly do that.
Joel gave it several years ago by his brothers. Which was very. How long ago was that?
Yeah, it was probably about 4 years ago. My brother had a very serious illness and was in an ICU for several weeks, and I sat there and had to be brother, but eventually could not be involved in some of the care. So
Challenges of being a caregiver and a physician, how do you kind of wrestle with those things? Talking about a former noon conference. Residents, what do you think? Is this something, how do you get that longitudinal outpatient management piece? What do you take away or observe from this type of paper or noon conference and those things? Any thoughts you all have?
I think this is hugely beneficial. We definitely have this link back to school. So it was really great from that standpoint, but I feel like getting more resident perspective lot of empathy and to like, of course, struggle with them as you're going through residency, you're trying to do the right thing all the time. Sometimes the patients get enough of stage.
Maria, as a great point, we were talking about this at dinner last night, is, you know, this is also an opportunity to talk about some of those challenges of just managing a patient. Are you doing the right thing? And how do you figure out what that right thing is to do when most of the decisions we make aren't just yes, anti-seizure medicine or no, non-anti-seizure medicine? You know, it's that difficult gray area in between. And this is a chance to kind of talk about that. It can be helpful for learning. Yeah.
Yeah, River's one of my best friends, this guy, and we went to medical school together and we have these. And one, there's just really powerful one in the sense that giving that patient that platform. I think there's therapy in that, but then it also it reveals how vulnerable we are because they get to see us discuss the gray, the complexities. And I think that gives an insight to what we deal with. And I think that's powerful to let that for patients say like, oh wow, I think those guys, they just appreciate what we're thinking through and they feel maybe more cared for sometimes.
Yeah. Two important points from the inspiration of Rivers in the back was yeah, I mean, yes, in clinic we're not always talking about the all of that why behind the decisions. This is what the decision is, and this noon conference was a sort of safe space to discuss those things, and the patient did, you know, benefits, and that can be of value. So, well, we are at time. Oh yeah, yeah.
One thing we need is a couple of patients come in and talk to the residents back about what it's like to try to park at you to go to clinic and do yourself, and then how often they get lost trying to find.
Yes, Dr. O'Brien makes a great point.
And the residents are mad at them.
Exactly. So the next grand rounds, HR will be invited, and we'll bring a patient in and just talk about how terrible it is to be a patient and navigate all these health systems that we have. And then you can survey HR and see if they've learned something from, you know, from those sorts of things as well. Yeah, it's you know, hopefully the conversation can continue. I hope you'll pick up the journal and kind of take a look at some of the things going on. More importantly than that, I hope that you can use that to create some conversations with your educators and kind of teams here about, you know, how you're doing things differently. And we look forward to Dr. Eckstein and group's submission on your experience with increasing outpatient exposure kind of in neurology. So thanks very much for having me, and happy to take questions.
Really not mad.
Good to see you, Katie.